afternoon, everyone. Welcome to ISCP 2021. I am Jiang Yan, APN working in Cardiac Intensive Care Unit, Tock Seng Hospital. This is the plenary session on cardiovascular implications of COVID-19. Today, we are very honored to have three distinguished speakers here with us. And Professor Avanzas, he is the chair of this session, and he's also the first speaker for this plenary. Professor Koji, Professor George Dan, and today's moderator will be Professor Mark Chan. And these are some disclosures. The content of this webinar is copyrighted by the ISCP and should not be distributed without the prior permission of the ISCP. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of ISCP. The session will be live streamed via Wonder and the ISCP and the APSC Facebook and YouTube pages. The European Board of Accreditation in Cardiology grants CME point for attendees who attend the full session. You will receive your certificate of attendance upon completing a survey sent via email after the webinar. And please post your questions in the live Q&A box if you have any. And at the end of the session, if you still have questions that we did not answer you, please email us with the email address provided at the bottom. Okay, Professor Avanzas, he is our chair and also first speaker of the session. He is a director of the Interventional Cardiology, Central University Hospital of Asturias, Spain. And he's also the Executive Committee, ISCP. Professor Avanzas, please.
Hello, good evening. It's a great pleasure to me to participate in the 26th Congress of the International Society of Cardiovascular Pharmacotherapy. My topic is COVID-19 and the cardiovascular system. My name is Pablo Avanzas. I'm professor of medicine in Spain, in Oviedo. I'm also a consultant in interventional cardiology, and I belong to the executive committee as a secretary of the ISCP. I'm also associate editor of International Journal of Cardiology and Revista Española de Cardiología. It's a local journal in Spain. I'm also deputy editor of the European Cardiology Review. This is the official journal of the ISCP. I have nothing to disclosure. First of all, I would like to thank you, all the organizing committee, particularly the chairpersons, Jack Chan and Kenny Singh, also the scientific chairs, that's Doreen and Mark Chan, and also all the members of the scientific members. This is the opening plenary. The topic is the cardiovascular implications of COVID-19. I will give a brief review of the COVID-19 and the cardiovascular system, and also it's a pleasure to work with people like Professor Koji, Hasegawa, and also George Dan. They are friends, and thank you very much for your contribution to this session. Also, I would like to thank you, Jiang and Mark Chan, for the availability to moderate this session. This is the summary. I will give a brief introduction, the COVID-19 disease, the cardiovascular manifestations, and finally the conclusions. Going to the introduction, you know that coronaviruses are viruses that are causative agents of common colds. We have suffered two previous recent outbreaks due to these viruses. The SARS in Asia with 8,000 cases and 800 deaths, and the MERS pandemic in Saudi Arabia, and also affecting 27 countries with 2,500 cases and again 800 deaths. Now we are in another pandemic due to an emerging viral disease that was originated in Wuhan in China. It's believed to have an origin as a zoonotic origin, starting in animals in Wuhan markets. The transmission is person to person, and by March 25th of 2020, we had nearly 20,000 deaths and 200 countries have cases of this new disease. This is the virus. It's a novel coronavirus named Severe Acute Respiratory Syndrome Coronavirus 2, the SARS-CoV-2. This virus was identified as the cause of the outbreak, causing with a respiratory illness mainly. The disease was named Coronavirus Disease 2019. This is the COVID-19. This is an illustration created at the CDC and reveals the morphology of this virus. Note the spikes that are on the outer surface of the virus, and also a number of proteins. This figure shows how we are now with the pandemic in July. As you can see, we have nearly 200 million cases with 4 million deaths. And you can see that it's affecting nearly all the world. In Europe, we have in Spain and also in United Kingdom bad numbers now. In Spain, we are now in the 5th wave. So in spite of vaccination, we have a great prevalence in those people not vaccinated that are mainly the young people now. The pandemic now is affecting young people in Europe. Let's go into the COVID-19 disease. The key features of the SARS-CoV-2 is that with the spike proteins, this virus binds to ACE2 receptors on host cells, mainly in the respiratory tract, and then the virus replicates and transmits person to person when an infected person sheds the virus. There are ACE2 receptor distributed across nearly all organs, so a number of organs in our body. The main organs affected are lungs, heart, and vasculature. In this slide, you can see how is divided the disease progression over the time. Is divided into 3 pathological phases: an early infection phase, a pulmonary phase, and finally a severe hyperinflammation phase. The early infection phase is characterized by viral infiltration and replication. Lymphocytopenia is a key laboratory finding at this stage. The disease progresses into the pulmonary phase, characterized by respiratory compromise and abnormal chest imaging. And stage 3, in this stage, we can see an exaggerated inflammatory response driven by the host immunity, and inflammation markers are elevated at this stage, and secondary organ damage becomes apparent. This figure illustrates long-term sequelae of this novel disease. After resolution of the acute illness, prior infection with SARS-CoV-2 may result in persistent manifestations of the disease. In the figure, you can see the concept of progression of the time divided into 3 phases: the acute phase, convalescent, and chronic. Assuming clearance of the virus in the acute phase, host response likely shapes the manifestations of the disease in the convalescent and chronic phases. Manifestations at this point are largely unknown and are actually under investigation. This is the course of the disease. As you know, mild or asymptomatic course is reported in nearly 80% of the patients. Severe disease is developed in 15% of the patients with dyspnea, hypoxia, and also lung involvement with imaging impact within 24 or 58 hours. And finally, a critical disease is suffered in 5% of the patients with very severe complications with respiratory failure, shock, and even multi-organ dysfunction. Let's go with the cardiovascular manifestations. These are the proposed mechanisms of cardiac injury in patients with COVID-19 disease. Cardiac injury can result via direct or indirect mechanisms. The direct mechanism involves viral infiltration into myocardial tissue, resulting in cardiomyocyte deaths and inflammation. Indirect mechanisms include cardiac stress due to respiratory failure and hypoxemia, and cardiac inflammation secondary to systemic hyperinflammation. Biomarkers, arrhythmias, myocardial infarction, and heart failure are manifestations of myocardial injury. These figures summarize the cardiovascular involvement of this disease as acknowledged by the European Society of Cardiology. The SARS-CoV-2 anchors on transmembrane ACE2 receptors to enter the host cells, including type 2 pneumocytes, macrophages, endothelial cells, pericytes, and cardiac myocytes, leading to inflammation and multi-organ failure. In particular, the infection of the endothelial cells or pericytes could lead to severe microvascular and macrovascular dysfunction. Furthermore, in conjunction with the immune overreactivity, it can potentially destabilize the atherosclerotic plaques and explain the development of acute coronary syndromes. Infection of the respiratory tract, particularly of type 2 pneumocytes, is manifested by the progression of systemic inflammation and immune cell overactivation, leading to the feared cytokine storm, which results in an elevated level of cytokines such as IL-6, 7, 22, mainly. Subsequently, it is possible that activated T cells and macrophages may infiltrate infected myocardium, resulting in the development of fulminant myocarditis and severe cardiac damage. This process could be further intensified by the cytokine storm. Similarly, the viral invasion could cause cardiac myocyte damage directly leading to myocardial dysfunction and contribute to the development of arrhythmia. In conclusion, this novel disease outbreak caused by SARS-CoV-2 represents the greatest medical challenge seen in the last decades. Main cardiovascular manifestations include acute coronary syndromes, heart failure, myocarditis, arrhythmia, venous thromboembolism, metabolic syndromes, and also is described Kawasaki disease. I truly believe that understanding of the effects of COVID-19 on the cardiovascular system is essential for providing comprehensive medical care, including treatment for cardiac and COVID-19 patients. Thank you very much for your attention.
Thank you very much, Prof. Avanzas, for this excellent overview of cardiovascular system and COVID-19. If you have any questions for Prof. Avanzas, please write in the chat. It will be discussed during Q&A session. Please allow me to introduce our second speaker, Professor Koji. Professor Koji is the Director, Division of Translational Research, Kyoto Medical Center. He's a leader, Clinical Research Network, National Hospital Organization. Clinical Professor, Faculty of Medicine, Kyoto University. He is also Executive Board of Director, ISCP. Professor Koji is going to share with us on this exciting topic, myocardial injury and coagulopathy in COVID-19. Professor Koji, please.
Thank you very much for the invitation to 202 Singapore. Congratulations for a great success. And I'm Koji Hasegawa from Kyoto. So my today's topic is myocardial injury and coagulopathy in COVID-19, a boon or bane when using anticoagulation. So this is the original data from China. More than 40,000 PCR confirmed patients. More than 80% of patients are mild or asymptomatic, but around 5% of patients result in severe states, and the mortality is around 2.3%. But mortality is quite different from country to country. And generally, the mortality is high in Europe and America, but low in Asia. And the ACE2 is basically a protective molecule for cardiovascular system and converts the vasoconstrictive angiotensin 2 into vascular protective angiotensin. And ACE2 serves as a receptor for the SARS coronavirus 2. ACE2 is abundantly expressed in the alveolar epithelium, so causes massive pneumonia. This is the main pathway. And ACE2 is also expressed in the myocardium, possibly cause myocarditis. And ACE2 is expressed in the vascular endothelium, therefore causes thrombosis and result in myocardial and pulmonary infarction. And this is well-known data that elevated troponin level cardiac injury was strongly associated with prognosis. And you can see the elevation of troponin levels patients and more than 50% of mortality. But in patients with normal troponin level, the mortality is less than 5%. And this is the case report come from New England Journal of Medicine. Among 80 COVID-19 patients with ST elevation, so-called STEMI, 8 patients were diagnosed as myocardial infarction due to coronary artery obstruction. But other 10 patients were diagnosed as non-coronary myocardial injury. So non-coronary myocardial injury is very frequent in COVID-19. So the possible mechanism of myocardial injury include acute coronary syndrome due to the rupture of the atherosclerotic plaque or coronary spasm, obstruction of myocardial small coronary arteries due to enhancement of coagulation activity, global ischemia resulting from hypoxia, circulation insufficiency due to pneumonia and shock, and myocardial damage caused by cytokine storm induced by the strong release of inflammatory cytokines, and the last is the possibility of viral myocarditis caused by the direct binding of SARS coronavirus 2 to cardiac myocytes. So SARS coronavirus 2 exists in the heart of a died COVID-19 patient. This is a report of the 39 consecutive autopsy cases from Germany, and a large amount of virus exists in more than 40% of cases, but no virus was found in less than 40% of cases. In addition, around 13% of patients minor strand RNA was detected, indicating replication of SARS coronavirus 2 occurs in the heart. And the presence of SARS coronavirus 2 in the COVID-19 heart was associated with increased cytokine responses, such as the increased gene expression of inflammatory cytokines, including TNF-alpha, interferon gamma, chemokine ligand 5, and interleukin 6, 8, and 18. And such gene expression was higher in the heart with a large amount of virus than no virus heart. However, infiltrate of inflammatory cells was similar between a large amount of virus heart and no virus heart, suggesting that typical myocarditis is not so frequent. However, inflammatory cytokine expression exists with abundant viruses in the heart. So the summary of myocardial injury in COVID-19 is the elevation of blood troponin level. Cardiac injury is strongly associated with death in hospitalized patients. Cardiac injury, elevation of troponin unrelated with epicardial coronary artery obstruction is frequent. SARS coronavirus 2 exists in the heart of died COVID-19 patient and is associated with inflammatory cytokine expression. And this is the data of the cardiac magnetic resonance 2 months after the recovery from COVID-19. And at this time, the high sensitivity troponin T was detectable in 70% of patients, and abnormal cardiac magnetic resonance findings were observed around 80%. So there is a possibility that myocardial damage continues more than 2 months after recovery from COVID-19. So a careful follow-up will be needed. So this is the data come from New York City incident of thrombotic event in hospitalized 9 patients with COVID-19. And overall, the 16% of patients occurs, thrombotic events occurs. But in ICU patients, severe patients, around 30%. And non-ICU patient, mild to moderate patient, and 11%. However, in Japanese data, the thrombotic events are low, overall only 1.9%, and in moderate, mild to moderate cases, 0.6%. In severe cases, 13%. So generally, it seems that the agents are low in thrombotic events. And this is a report of the meta-analysis of the 17 studies on the anticoagulation therapy and in-hospital mortality. In this study, the prophylactic regimen was defined, for example, enoxaparin 40 to 60 milligram per day and apixaban 2.5 milligram bit per day. And the therapeutic regimen is the standard or more doses of heparin overdose. And you can see, compared with no anticoagulation, prophylactic anticoagulation reduced in-hospital mortality around 17%. But therapeutic regimen of anticoagulation therapy increased in-hospital mortality. And the major bleeding, no anticoagulation, 3.5%. The prophylactic regimen, 2.3%. So did not increase the major bleeding. But the therapeutic regimen, the major bleeding was 9.6%, around the threefold compared with the no anticoagulation or prophylactic regimen. So, and this is the same paper, come from the same paper. And actually, prophylactic anticoagulation was performed in much less in Asia compared with Western. In Europe, anticoagulation was performed in 90% and North America 83%. But in Asia, anticoagulation was performed only in 26%. And the prophylactic anticoagulation decreased in hospital mortality only in Western, but not significantly reduced in hospital mortality in Asians. So in Asia, the anticoagulation was performed much less, and also the beneficial effect of a prophylactic anticoagulation is not clear at present. So this is a summary of anticoagulation therapy in COVID-19. And the coagulopathy is one of the main mechanisms leading to death in COVID-19 patients. And prophylactic dose, but not the therapeutic dose of anticoagulation therapy is beneficial to improve prognosis in Western. And the thrombotic events in Asians are much less compared with Western. The role of prophylactic anticoagulation needs further evaluations in Asians. Thank you very much for your attention.
Thank you very much, Professor Koji, for this insightful sharing and clear, concise recommendations for anticoagulation strategies for COVID-19 patients. Yeah, let's welcome our third speaker, Professor George Dan. He's head internal medicine clinic and cardiology department. He is senior consultant of cardiology and internal medicine, senior researcher first degree, Colentina University Hospital, Caro Davila University of Medicine, Bucharest, Romania. He is also past president of ISCP. Professor Dan is going to talk to us on this up-to-minute updates on the empiric enthusiasm and evidence-based disappointment of drug therapy in COVID. Professor Dan, please.
Hi, I'm Dr. George Dan from Romania, and I must talk shortly about the deceptions and satisfaction of COVID-19 therapy. I have no conflict of interest to declare for the present presentation. Usually, a risk assessment should be based only on well-established scientific facts. This means from data to scientific corpus and to policy. This is not always possible, as in pandemics, when data should be rapidly translated in the policy. On the other hand, public accept extremely low values for risk. But the real possibilities to identify risk are far from ideal. This explains why a plethora of drugs and attitudes issued at the beginning of the pandemics without a solid scientific support. Some were considered positive for COVID outcome, like azithromycin, antibiotics, lopinavir, ritonavir, favipiravir, or vitamin C or zinc or ivermectin. Some were considered with negative impact of outcome, like non-steroid anti-inflammatory drugs, statins, oxygen, vaccination, and even doctors. The result was a quite dangerous empirism concept, the so-called compassionate therapy, applying therapy without evidence-based. The scientific fog was further augmented by the low quality of the published evidence, as you can see from this publication of Stefanini in a Repertoire Journal, and you can see the low grade quality of evidence for the published papers after 2020 compared to 2019. And this situation was further complicated by a high level of political interference of science. And here in the slide, we have only several examples and papers regarding the politicization of science. Finally, the complex picture of COVID-19 and of possible target drugs is blurred by the high degree of interaction with usual drugs for the fact that COVID-19 patients are not always in the good health. The beginning of the beliefs-based medicine was the short and incomplete report of Gautre about hydroxychloroquine, creating the myth about this medication, despite the fact that there are no randomized controlled trials or systematically reconfirming these small studies. This was followed shortly by unproven beliefs on azithromycin and ivermectin. A good sign came from the recovery study, which demonstrated the benefit of dexamethasone. However, this benefit was observed only in patients on supplemental oxygen, but not in patients with not requirements for supplemental oxygen. Other studies and meta-analyses confirmed the benefits of corticosteroids in critical patients, including hydrocortisone and methylprednisolone. Also, we had good signals for remdesivir from the study ACT-1, especially when this drug was administered early during the disease. However, the large WHO study Solidarity, including more than 11,000 patients, comparing several already used medication in COVID, like remdesivir, hydroxychloroquine, lopinavir, ritonavir, and interferon, failed to demonstrate any benefit for remdesivir and confirmed the lack of benefit of hydroxychloroquine. Remdesivir was, however, included in the FDA recommendation. The recovery study evaluating the benefit of interleukin-6 antagonist in COVID included also tocilizumab, especially in patients already on corticotherapy 97 since June 2020. And this study demonstrated a significant benefit of tocilizumab versus usual care in patients with critical, especially critical COVID manifestation. JAK1/2 represents also an attractive final target against inflammatory syndrome in COVID. And the study ACT-2 compared baricitinib plus remdesivir versus standard of care plus remdesivir demonstrate a trend of benefit, significant statistic in favor of baricitinib. Many studies evaluating anticoagulation for COVID patients were done in different settings, in outpatients, hospitalized patient, ICU, or post-discharge, including different antithrombotic agents and in different dosages. As per guideline now, and you have here the National Institute of Health and the American Society of Hematology, there is no recommendation for full dose of anticoagulation excepting the patient with other indication for anticoagulation. And there is an indication for prophylactic anticoagulation for patients hospitalized for COVID-19. However, there are no data to recommend the anticoagulation on the routine basis after discharge. In summary, only remdesivir and dexamethasone were confirmed for stage 2 and 3 of disease together with prophylactic anticoagulation. And this view is confirmed in the European Respiratory Society guideline this year, in which corticotherapy and anticoagulation are strongly recommended together with supportive care, and also with conditional recommendation for critical patients for interleukin-6 inhibitors, especially tocilizumab. However, ladies and gentlemen, looking at different regional guidelines, you can see here in this busy slide several countries, you can see there is a large degree of the freedom despite evidence-based medicine. So several drugs are still indicated despite the lack of evidence-based medicine, including lopinavir, ritonavir, including favipiravir, including hydroxychloroquine or chloroquine. Moreover, as pointed out by this interesting paper published in Nature, 40% of the present studies included only a small number of patients. And on the other hand, there is a huge degree of wasted research through duplicated studies. And you can see here the impressive number on hydroxychloroquine, despite the very clear lack of effect of this drug. So, ladies and gentlemen, it's difficult to finish this presentation forgetting what Voltaire noticed once. Doctors put drugs of which they know little into bodies of which they know less for diseases of which they know nothing at all. Thank you for your attention.
Thank you so much, Professor Dan, for these up-to-minute updates on the pharmacotherapies that we use during COVID-19. And let us invite back our speakers, Professor Koji, Professor George Dan. And unfortunately, Professor Avanzas is not able to join this Q&A session. If you have specific questions for Prof Avanzas after this session, please write your questions in the email provided. And today, we are privileged to have Professor Mark Chang joining this Q&A session. Professor Chang is a senior consultant cardiologist from National University Heart Center, Singapore. Professor Chang, please.
Thank you very much, Yang Yan. The questions from the audience have been probing and insightful, and I will have to turn these questions over to Prof Dan and Koji. I think the first question of interest, because we have a very large Asian audience, is whether there seem to be ethnic differences in terms of the thrombotic complications with COVID infection, as well as whether the anticoagulant strategies may have to be tailored differently. Perhaps Prof Koji, you might want to take that question.
Yes, thank you very much. And as Professor George Dan described, and I think in Europe, and anticoagulation therapy, prophylactic anticoagulation therapy is routinely performed after hospitalization. But I think in Asia, not performed routinely, and just only 26% of patients anticoagulation therapy is performed. We have many discussion about the guideline, and many people think that in Asia, thrombotic events are much less. So we do not recommend to perform the prophylactic anticoagulation therapy. So we need further evaluation about whether the prophylactic dose of anticoagulation therapy is needed or not in Asia, but definitely needed for Europe and America. And also there are questions about anticoagulation therapy is not so beneficial in Asia, I talked. And this may be just due to the low thrombotic event in Asia, probably. Thank you very much.
I would like to ask a question related to the increasing incidence of COVID vaccination-related cardiovascular and thrombotic complications. The first would be with the live attenuated virus vaccines. We are seeing an increased incidence of venous thrombosis and what we now call VITT, or vaccine-induced thrombocytopenic thrombosis. Can you give us some strategies on how to potentially avoid that and treat that if such complications occur?
Can I answer to this?
Yes, please, Prof Dan.
Obviously, I have not an answer to how to prevent such adverse reactions. We don't know at this moment who are exactly the risk persons for such difficult evolution under the vaccination. We know figures, and we try at this moment to find the risk person. Probably there are some genetic predisposition, there are some inside disease not really expressed at the moment who potentiate the risk. What I can say, I would be very careful in affirming the increased proportion of the adverse reaction. In fact, I don't think that is an increased proportion of adverse reaction if we compare with other vaccines. We are only in the way to recognize the adverse reaction for the vaccine. And if we put together the reality of the adverse reaction, like the thrombotic reaction with AstraZeneca vaccine, like myocarditis with Pfizer vaccine, and the anaphylactic reaction with the RNA vaccines, we can see that the number is extremely low compared with patients without such kind of reaction. So indeed, the myocarditis in the Pfizer vaccine is a problem. I remember 2 patients I had very severely in a huge cytokine storm, very difficult to treat. We have no protocols. But for the scientific point, I would be careful in with the proportion of describing the adverse reaction compared to the benefit of the vaccine. I am expecting even more adverse reaction, even more than thrombotic and myocardial disease with vaccine. But this is only the evolution of our thinking and not really the limits of the vaccine we have at this moment.
Thank you very much, Prof. Dan. Maybe I'll just finish off with one final question, because there seems to be quite a lot of interest again, now specifically with respect to mRNA-associated myocarditis. Profs Koji and Dan, what do you think is a possible mechanism of these myocarditis events that we're particularly seeing in younger men who receive the mRNA vaccines?
Okay, thank you very much for the question. That myocarditis after the vaccination is reported, but probably due to the immune reaction, it also occurs vaccination against the influenza virus. So it's a common event after vaccination. But the frequency of myocarditis after vaccination is 1 person per 1 million. And also just the natural occurrence of myocarditis is 0.3 per 1 million. Well, it's more than the natural causes, but the frequency is quite low, and most of the myocarditis patients after vaccination recovered. So apparently the benefit will exceed the demerit. Okay.
I could add only one thing to what Koji excellently said, that one possible cause of this, and we need to individualize a person prone to this kind of mechanism, it's so-called antibody-enhanced disease. In several persons, the antibody are able to enhance the inflammatory response from the macrophage and monocytic cell. And this phenomenon explains why, in several cases, the vaccination could give a disease which is even more florid, more malignant than the natural disease.
Thank you very much, Professors Koji and Dan. I think this was a great session and terrific insights from our 2 expert speakers. If there are no other questions at this point, I'd like to close the session. And thank you very much to ICSP for organizing this session.
Thank you.
Thank you.
Thank you, Professor.